comes up a lot, with our standard Chiari decompression, we're often doing a C1 laminectomy. We leave the joints, we're always so careful not to go down to 2. I often get asked, does that cause instability just by doing that? Can you just make a comment on that? In the spine world, what do you say?
I feel pretty confident that it does not in a normal spine. I think in a disordered spine where there exists already abnormal alignment in the cervical spine already, it very well could cause a worsening of the ligamentous tension band in the posterior neck. But with that being said, it's not the laminectomy that's doing the destabilization. It's the actual removal of the soft tissue attachments to that lamina. I think what's key is to not detach all of the muscle attachments to the C2 spinous process and lamina, because there exists a number of muscle groups that attach primarily to that complex, to the skull and to the lower cervical spine. So, it would be wonderful if that could happen on all of the Chiari operations. I realize that there's certain Chiari operations that require a much bigger exposure or bigger laminectomy. So it's ideally to minimize the muscle exposure would be ideal.
Okay. Dr. Gerard, just a question about the coat hanger syndrome. We've talked about this a few times. Mechanism, or we talked about it from a leak perspective, POTS. What do you think? Orthostatic hypotension.
Right.
Where's that coming from?
Yeah, so that's always a complex question.
Yeah.
But basically, when you have very chronic orthostatic hypotension, the central nervous system has a very remarkable vascular capacitance phenomenon. It's called, auto-regulation or auto-circulation. So if you've had chronic orthostatic hypotension over time, the blood vessels in the brain, as well as some of the quote-unquote dormant capillaries in the brain, begin to dilate to increase the vascular capacitance in the brain. And as a result, you become less and less aware of your orthostatic hypotension because the awareness is in your brain. But you don't have that mechanism in your cervical paraspinal region and your upper trunk region. So all of a sudden, the awareness of your orthostatic hypotension begin to shift to your cervical spine and shoulder region. And as a result, you develop this coat hanger kind of a symptom, which classically also resolves when the patient lays supine. So that's how you know it is not due to a structural spine disease. But it's because really the brain accommodates. Unfortunately, the upper muscles and the upper spinal cord does not accommodate.
Okay, no, thank you. We think about this a lot. Syrinx pain, the shoulder. Oh, yes.
So, I find this very interesting because, coming from your perspective, that's what, you would predict it was. And coming from my perspective, I think, the fluid is not causing buoyancy of the nerve roots. And therefore, when you lose CSF volume, that there's more of a drag on the nerves in the upper cervical spine as a consequence. So coming from your perspective, it's like more central mediated, and coming from my perspective, it's more a buoyancy problem and a mechanical problem actually from the drag on the nerves, since, we know in low CSF pressure, there's a drag on the nerves intracranially as well. So anyway, interesting different perspectives, given where you're coming from.
Thank you.
Yes, question.
Can I just make a comment on that? Because that's very, very interesting. It was a fantastic session. Thank you. So in pregnancy, the fludrocortisone and aldosterone effects are blunted by the progesterone. So the progesterone and the estrogen basically tell the aldosterone to shut up, and they get on with expanding the volume. So the heart gets bigger, the kidneys get bigger, the heart increases. I think it's something of the order of about 40 to 50% heavier at the end of pregnancy. And also the cerebral vessels remodel in exactly the way that you say. So the fact that this could be happening when you're not pregnant as a way of compensating for dropping blood pressure is quite stunning. And also, the fact that there are two theories doesn't mean to say that either of them are wrong, because they're going to be happening in different people. So anyway, just big compliments, and I'm very impressed. Thank you so much.
Yeah, really interesting point. Pregnancy, yeah. And another quick thing for Dr. Iskandar. So occult tethered cord, I know Dr. Klinge is not here, but normal imaging, when do you decide to release the phylum? I know it's a loaded question, but just give your sense. It's rare, but it can be needed sometimes, perhaps. Progressive Syrinx or neurologic symptoms. Any time you would do that?
So there is huge controversy about this topic, as you know, Chiari. There are centers that do a lot of these surgeries. There are centers that do no surgery. I would say the majority of us will see one in a blue moon. We'll see maybe one every year or two. It's a reflection of a field that doesn't have it together yet. We don't really understand what we're doing. Whenever we operate on something that is not visible on imaging, then you're taking a leap of faith. Now, this is coming from someone who does Chiari zero operations, so I understand that we're limited in our capacity to understand this type of disease that's not visible on MRI. I know it does exist. I just don't know how significant it is. And I will give just one quick example. Urodynamic studies. A lot of these studies that are done, a lot of these surgeries are based on abnormal urodynamic studies. Well, we don't even know what normal urodynamic studies are supposed to be like in normal children, because we don't usually put a Foley catheter in children and do urodynamic studies on them. So we don't really have a baseline to determine that this 6-year-old or 4-year-old who hasn't really toilet trained yet has an abnormal, it has an abnormal study. So I really can't answer your questions except to say that we have to be very, very careful how to, make these diagnoses. I suspect, I think that it does exist. I just don't know how to determine. I'll flip it back to you. What do you think?
No, I agree. I brought it up. It's a loaded question because we don't have an answer. And I think it's important for you all to hear the spectrum that we just don't know. There are situations, it may make sense, but it's sure not something we want to do a lot of without knowing that it clearly can help someone. So we're cautious about this and we're trying to understand it more. But we need to study it. Dr. Heiss, I was just going to call on you. Perfect. Well, let's get you a microphone. Hold on a second. Hold on. Here we go.
There aren't many randomized controlled studies in neurosurgery, but there was one on occult tethered cord, which means the conus is in the normal anatomic position. And that study showed that the medical group and the surgical group did the same. Actually, the medical group did slightly better. However, that study was a little bit underpowered, so there are some people who don't like that study. The other thing is that Mike Scott, who's recently passed away, a pediatric neurosurgeon, he said that if there was a lipoma in the phylum, that would increase your chance of someone who had occult tethered cord doing better with sectioning. So those are my comments. I don't know if you agree or disagree.
I agree with your comments. And what's going on in Spain? Can you comment on that?
Well, that's very controversial, but in Spain, for Chiari patients, they release the phylum, but generally they release the phylum below where we would in the U.S., below where the dura ends. And there have been editorials about that by other groups, and they say that the quality of evidence is low for that helping. But I have no firsthand information, so I just have secondhand information from what I read.
Yeah, no, good points. Questions from the audience?
Jerry, just a
Yeah.
quick thing. So 6% of normal population have fat in their phylum. So we need to be, and that's a Duke study from McClendon. Yeah. So question, huh? But the other thing is, I mean, this is a symptom of a bigger problem, right? So when you look at Chiari malformations, how many of the presentations for Chiari are purely subjective, and how many are truly neurological, where we can detect them on exam? Someone who comes in with a headache or neck pain, we're suspecting it's a Chiari symptom, but what if it's not related to the Chiari? So this is what we're talking about, is subjective symptoms without an obvious neurological deficit that you can see on exam, that you can actually measure.
Other questions?
Hi. As a mental health clinician, I get clients, and I was very interested with the POTS and generalized anxiety disorder, because I do get clients, and when I'm going through the diagnostic process and the treatment process, and they don't catch on, what is something a mental health clinician could do to really get a physician to say, well, maybe we've got more than generalized anxiety, or that it could be more physical? Because I always have clients, my practice starts at 3 years old, so I see children to all ages. And sometimes the treatment it's just missing. None of it's working. And so I'm just curious as how within the mental health community and this piece, because we often get, it's all in your head, go see a clinician, and then we'll come back and talk to you.
Yeah, thank you for the question. So like I mentioned briefly, POTS really is not a disorder of anxiety. But you can have both, right? I mean, the two conditions are not mutually exclusive. And obviously, you can then interplay. So if you have a pre-existing anxiety disorder, then for some reason you develop POTS, it can play on each other. I think usually I would start probably by keeping things simple and see if you can document the POTS. So you could do a standing test, in the clinic, up to 5 minutes and see what happens to the heart rate. Do the symptoms improve when the patient lay down? And if you're not sure, you can always request a tilt table test, from a cardiology colleague if you don't have an autonomic center near you. And if you have POTS, then that should be, I think, managed. And then you see what does it do to the anxiety. So if it alleviates it, maybe POTS was the reason for why the patient was developing all these issues. But sometimes you can't completely alleviate it, so you can give something like a low-dose beta blocker, but some of these patients, we end up putting them on a very low-dose SSRI, for instance, to help them with their anxiety after we fix the POTS. So you can have both of them. A small percentage of patients have the tachycardia just from the anxiety, but usually it's not really orthostatic. When you test them, you can tell. Yeah, but thank you for your question.
I'm curious, I love the fact that you have criteria in your world that we don't have. I'm jealous of that. But then I think about this, traumatic brain injury and other conditions we treat, intracranial pressure, those numbers are quite arbitrary, actually, of what's bad and what our goals are. So the 15 millimeters of mercury, 30 millimeters of mercury, just give us a quick synopsis of how those were developed or validated.
Well, I'm flattered by your introductory comment, but it's not as numerically sensitive and scientific as you think. The criteria were really developed based on standardized population control data. So, you take a group of adults, you take a group of children, you either stand them in the clinic or you tilt them, and you collect data up to a certain, criteria, and then you measure 2 to 2.5 standard deviation above and below the mean. And that's how the criteria were started. And the reason I'm always mindful of that is because sometimes, I have patients who come to see me and, they are sent, for instance, for POTS. But then when I do their tilt test or stand test, they go up by 27 beats, not 30 beats. Do they have POTS? Or are they anxious, or don't they have POTS? Well, I think, one thing we don't think about is there is a cyclical variation in the symptoms, and there is sometimes a diurnal variation in the symptoms. So, for instance, patients with orthostatic hypotension and some patients with POTS feel much better in the second half of the day. They are much more symptomatic in the first part of the day. So if you test them in the clinic or in the lab and their appointment is at 3 p.m., they may surprise you by not crossing the line that you've defined as abnormal. While, if you test them at 7 a.m. or 8 a.m., particularly if they've been NPO, no oral intake for a couple of hours, which is what usually we do before the test, you may basically stress the system enough to catch it. So I think that's a little bit of a definite weakness. I would say overall the criteria are reasonably valid because we end up probably missing one way or another, no more probably than 10%. But I always listen to the patient history, and if it makes sense, I believe the patient, number one. Number two, the way I see it from my practice is if the testing does not meet the criteria, that doesn't mean they don't have the condition. That means probably I should just be conservative managing them. I do not need to be very aggressive putting them on 2 and 3 drugs if the condition is that mild, but that doesn't mean they don't have the condition. Yeah.
My question was, I don't know who was talking about it, but for Chiari 2 with the, instead of doing like a fusion or decompression, to deal with the tethered cord. So I just kind of wanted to ask about that as far as like, I don't really want to give too much detail, but I was diagnosed with Chiari 3 as a child, and so I get the question, when did you have the decompression? Well, I had multiple surgeries at birth, but I don't really know how to answer that. As far as the tethered cord goes, that's like their plan of action is dealing with the tethered cord at this point. And so as an adult, it's kind of a scary thing. So as far as surgery in adults with tethered cord, is that something that you can live with? Is that something that needs to be taken care of? And when do you take care of that?
So, without going into too much detail, were you born with a myelomeningocele?
Yeah, I had the encephalocele.
Encephalocele, but not a
Yeah.
myelomeningocele.
I'm not sure.
Which means you didn't have a defect in the lower back.
I had closed spinal bifida.
Occult, yeah.
Mm-hmm.
So occult spina bifida is not the same.
Okay.
So you don't have a Chiari 2.
Okay.
Okay. Chiari 3 is a completely different diagnosis. In fact, I think what Jerry mentioned at the very beginning, the effort to reestablish a new nomenclature for this is really important because the 4 or 5 or 6 Chiaris that have been described have nothing to do with each other. Mm. The only 2 that are related are Chiari 1 and Chiari 1.5, really. Okay. So I don't think you need to worry. I mean, I'm not giving you medical advice, but that's not what we were discussing in the talk.
Okay.
Yeah.
Dr. Bhowmick, any follow-up?
I can tell you that I deal with a lot of patients with tethered cord as adults, just mainly because I usually am doing the tertiary or quaternary surgery after a previous detethering. And so I think my criteria for offering an operation are far, far greater than the children that get primary detethering surgery. For adults that have already had a detethering, the surgeries that we do are, a re-exploration and looking for the tether and finding it and somehow treating it either with a patch or another section. Or another operation that I do more often nowadays is the spinal shortening operation, where we actually put in screws and rods and actually take out a portion of a vertebra and then decrease the tension on the spinal cord by shortening the spinal column. That operation is a really big operation, and it has all sorts of complications and long-term side effects. And so I tend not to offer that surgery unless people start losing the ability to walk or have significant bladder dysfunction that is progressive. So it's a serious operation. Even the adult detetherings, part of the reason why I do less and less of those is because the rate of neurological injury from those operations become significantly greater with each detethering operation. So it's one of these things where when it comes to occult tethered cord, I have the advantage of knowing whether the first surgery worked, and if it didn't, then I'm very unlikely to offer a second or a third operation. But for folks that are obviously retethered, you still need to have really bad neurological symptoms before I offer surgery in an adult.
Okay, 2 more final questions, then we'll have to go to lunch.
I just want to say I'm a little surprised that there still sounds like some skepticism about occult tethered cord. I would just encourage y'all to really just consider the clinical checklist that Dr. Klinge is working on. My daughter was a patient of Dr. Klinge. Before surgery, she was presenting with increasing issues with her reflex, hyperreflexia, clonus. She got to the point she couldn't walk across her house without her legs just dropping her to the ground. She had daily dizziness, daily headaches. She literally could not even straighten her spine to stand up all the way. After her detethering, her reflexes have all become normal. Her legs work. She doesn't just drop. Her daily dizziness and her headaches improved. And even though she tends to not have the best posture, she can actually stand up straight. It was life-changing for her. And I look at her presentation and how it's mapping onto what Dr. Klinge is doing. And it really, for us and for her, captured and improved the symptoms. And this is she also does have Chiari and some upper issues, so we're still dealing with that, but it's such a relief that her legs work. And she was in a decline for 3 years, and nobody had any answers. And for her, she was tethered. So
yeah, I would like to clarify, please. We didn't say it doesn't exist. We're just saying because it's a controversial topic, there's a wide spectrum of people how they evaluate those patients. So, for example, when I mentioned that in my practice I do it maybe once a year, your daughter's situation is the type of person that we do it on, because there are obvious neurological deficits, right, that you're describing. What the controversial part is there are children that come in with questionable bladder problems and nothing else. And that's the biggest, I think, segment of the population that gets that type of surgery. So the person that described the occult tethered cord was Jerry Oakes, who trained us. And it's obviously something that exists. But we just have to, whenever we try to develop a diagnosis without an MRI finding, then we're going to make mistakes. And that's all I was saying.
Yeah, good thought. Last question.
Hello. Sorry. Could you and the panel share your algorithm for symptomatic pseudomeningocele after a Chiari 1 malformation, decompression, and duroplasty? And if so, what the success rate would be, and if it reforms, what your options are?
How soon after surgery you're talking about? Months or weeks?
8 weeks. 8 weeks post-op,
8
very
weeks.
slight swelling, and it's progressed now and is now symptomatic.
So getting worse, 8
Yeah.
weeks. Okay, yeah.
Well, beyond 8 weeks now, maybe more to 10.
We'll hold off on Dr. Jaradeh's treatment options, but Dr. Bhowmick, Dr. Iskandar.
The first step is to reoperate, to reclose. Now, if you have a suspicion that is going to be questionable in terms of the success rate, you can place a lumbar drain temporarily. In some situations, and I don't know what predisposes to those, maybe bigger opening than usual, or maybe the patient has some additional factors we don't know, they require shunting for a few months. It's usually, though, the most of the patients that I've taken care of with this, we were able to repair just by doing primary repair of the mouth.
I think the adult population is a little bit different in that a lot of times, as long as the wound is closed in the early period after the surgery, a lot of times you can wait, a fair amount of time and watch the pseudomyngesial actually decrease in size, because there's a fair amount of scarring that occurs in adults that is very robust, and overgrowth of tissues. And honestly, we actually have the opposite problem. We have scarring actually recompressing the posterior fossa or the brainstem. So I oftentimes will wait when a patient shows up in the early stages, like within 3 months of their surgery, and see if their symptoms improve over the next couple of months with potentially serial imaging. If it's growing, that's a different story. That's a bigger problem, and I might be a little bit more aggressive and offer an operation pretty early for a growing pseudomyngesial. If it's not growing and if it's shrinking, then I ask for some help from a friend, like potentially someone like Dr. Gray or somebody like that, to figure out is there something else somewhere else, there's a leak somewhere else or something like that. But this is just what I found personally, is that I see a lot of pseudomyngesials, some of them caused by me, from various other spinal surgeries, and a large proportion of them, in fact, the large majority of them, do get smaller. If they're getting larger, then that's a bad sign. Then that likely requires some type of intervention.
Yeah, I actually agree with this. I mean, I assumed you're saying it's a progressively enlarging pseudomyngesial.
Yeah. Yeah, sounds concerning. Enlarging on imaging and symptomatic. So you're kind of stuck for both. So, okay, great session. I thought this was really, sorry I went over, but there was a lot to get through, and I thought the QA would be really fun to kind of explore. So off to lunch. We'll see you back at 1 o'clock.